Moving on to the newer antidepressants is, what's the advantage of these drugs? They're more pacific, right? Anybody watch Duck Dynasty? I love that show. All right, so the SSRIs. I'm going to spend some time here because these are the drugs that you're going to see. I told you earlier that 1 in 10 Americans is probably on an SSRI, and that's pretty impressive, actually. Main thing is they're blocking reuptake inhibition. Side effect-wise, these are great drugs. Why do we use them so much? Well, they're tolerated. People do very well on them. There's not a whole lot of a side effect burden associated with them. With any of the other drugs that I've talked about today, I will always say, it's great except in this case, or if you have this disorder, or if you're old, or if you're young, or if you have seizures. There's really no indication in which you cannot give an SSRI other than serotonin syndrome, which even then I don't know that it's technically contraindicated. Basically, you can have any type of neurological, metabolic disorder imaginable, and you can still give an SSRI if you pick the appropriate one. So they're very safe. They're safe in an overdose situation. Side effect-wise, GI is what we see. That's probably, they're most notorious for GI side effects. You got a lot of serotonin in your gut. Think about the antiemetics that we use. They're heavily serotonergic as well. So we see a lot of GI stuff initially with it. In the previous lecture, I think they told you that it can be a little anxiety-provoking. So if you're treating depression and anxiety, I do the same counseling point of just saying this. You might feel a little bit worse before you start to feel better with this. So we go slower with these medications. Sexual dysfunction. When I said earlier that the most common reason people stop taking an antidepressant is sexual dysfunction, more accurately, the most common reason people stop taking their SSRI is sexual dysfunction. It's as high as 1 in 4, 1 in 5 with this particular group of medications. Much, much, much more rampant than what we see with all the other drugs that I would talk about today. Most of the other drugs, 5, 7%, most of them less than that. These, again, up to 25%, sometimes 30% in cases of fluoxetine, where we can see it much more commonly. So this is a big reason people stop taking them. They do have a withdrawal syndrome. It's a flu-like-y, general malaise, achy. Sometimes they'll talk about these almost electrical type feelings in their extremities, like a tingling in their fingers or toes that they get from a serotonin withdrawal. Again, not deadly, but it is quite uncomfortable for them. Let's see. Looking at these individually. So citalopram is a great drug. I don't have a whole lot to say about it. It does have a box warning for QTC prolongation, which I won't go into my 20-minute soapbox about my personal opinion on that. But they do cap the dose now at 40 milligrams with that particular medication. Other than that, it's very well tolerated. It's very clean from a side effect standpoint. It's very clean from a drug interaction standpoint. It's well researched. The biggest depression study ever conducted was done with citalopram, so it has great data behind it, and it tends to be very well tolerated. The weird thing about it is you can basically think of it in thirds. A third of the people you start on this drug feel a little tired, a third feel a little geared up, and a third don't notice anything. So we typically give it in the morning, and if people are that 1 out of 3 that gets a little sedated, we push it to bedtime. We also see less sexual dysfunction with this particular SSRI versus the other SSRIs. So a lot of times if people have done well on an SSRI but they're experiencing sexual dysfunction, we can switch them to citalopram, and most of the time they'll do well with that. I've done it. I got like a 50-50 track record with it. About half the time we do it, patients do incredibly well. The other half of the time, they still get the sexual dysfunction. We have to switch them to something else. Escitalopram is a wonderful drug because citalopram is a wonderful drug. What did they do? They had the R enantiomer and they had the S enantiomer, right? So they just called it escitalopram. They're very clever. The conversion between it's about 2 to 1. So 10 milligrams escitalopram is roughly 20 milligrams of citalopram. Interestingly enough, escitalopram doesn't have that QTC warning because it's this nasty, dirty R enantiomer that we want to blame for that. Again, I'll keep my opinions to myself on it. So it is as good of a drug. Some people would argue better. I personally think it's on par. It's a little bit more expensive, so I tend to lean towards the citalopram, which has been a $4 drug for ever and a day. Fluoxetine, or Prozac. I have a personal bias towards as well. I think it's a great drug. It was the first. It's the best researched. There's any disorder you can think of in psychiatry, they've looked at Prozac in it. it has that really long half-life, and that's a double-edged sword. If you are experiencing side effects, you might be having those side effects for a while, is the problem. But the great thing is if you miss a day of fluoxetine, 2 days, you go the weekend because you forgot about it, it's not the end of the world. Most people don't have a withdrawal to this medication because it has such a long half-life. Fluoxetine has about a 3-day half-life. Its active metabolite, norfluoxetine, has a half-life of about another 7 days on top of that. So it tapers itself out of your system. It's one of those medications that you can stop abruptly and people will do just fine on it. It tends to be a little more stimulating, a bit more of a pick-me-up, which is not always the greatest in anxiety, but I have yet to meet the depressed patient who says, I'm thinking about killing myself, I have feelings of guilt, I can't get out of bed, but I got all this energy and I don't know what to do with it. That patient doesn't exist. They're usually very anergic. So a little bit of a kick in the morning can sometimes be beneficial for them. Luvox, I won't say very much about fluvoxamine. Oh, sorry. Back up just 1 second. Very important. Other downside to Prozac, drug interactions. You got to pick your patients appropriately with Prozac. It has a lot of drug interactions. It's a big 2D6, CYP2D6 inhibitor. A lot of drugs in general, but a lot of drugs in psychiatry go through that particular pathway. So if you're ever starting somebody on fluoxetine and you notice that they're on concomitant psychiatric medications or just medications in general, run a drug interaction check or come find me and I'll run a drug interaction check for you because that can be significant as well. Fluvoxamine, it's really not approved in depression. It's mainly just generalized anxiety disorder and OCD. It is an SSRI. It's not very commonly used. I'd be surprised if you see it very much. It does have a lot of drug interactions as well. It's not quite as bad as fluoxetine, but it does have a significant amount of them. Let's see. Paxil, I have a different caveat towards. For depression, it's probably my least favorite SSRI. Reason being is of all the medications that fall into this particular class, this is the only one that has a mild anticholinergic component to it. Anyone in this room would do just fine and really not notice that. In elderly patients, when I first got here years ago, that was a big thing. I had to do a lot of re-education with people would send me a drug profile and say, hey, this patient was doing really well. The depression was coming around, and now they just seem a little bit out of it, a little disheveled. I don't know what's going on. I would say, send me a drug profile. And a lot of times they would be on paroxetine. In elderly patients, it becomes very significant. This is another big enzyme inhibitor, so drug interactions are a real concern. That cholinergic component tends to give more of a sedating component, not sedation in the sense that this is going to help you sleep, sedation in the sense that this is maybe going to make you a little tired and groggy with somebody who already is tired and groggy and anergic. In extreme populations, you guys know pregnancy categories, right? Do you know what pregnancy categories actually mean? Next to nothing. Pregnancy category A means safe, absolutely, right? Go for it. Pregnancy category X means avoided at all cost. B, C, and D sometimes don't mean much. It's based off animal studies, it's based off theory, it's based off of a similar drug. You really got to look into B, C, and D to see what that means. There's a lot of times where I would always use a C over a B because the C has been around for decades and I got a lot of safety data behind it. The B just came out yesterday and they did a study in beagles, which I'm not treating a whole lot of beagles these days. Otherwise, I might pay more attention to that. All the SSRIs are pregnancy category C. Paxil is a D, and this is probably a well-founded D, in my opinion. They saw a little bit more cardiovascular abnormalities. When they looked at all mothers who were treated with SSRIs, they saw it more in Paxil versus the other SSRIs. Also, stuff like pulmonary hypertension was more prevalent. Other consideration, like I said, we don't like using in the elderly. 1, because of drug interactions, 2, because of that cholinergic component. And the last special population is it's actually recommended against use for depression, run-of-the-mill depression in small children. They did a couple of studies in that whole suicide box warning that pops up that you guys are just going to love one day when you have to start doing education on it. A lot of that data comes from Paxil as well. So it's recommended against use in that population. So in extremes, not the best choice. However, it does have a role. That calming, that sedating effect is very calming in people who have anxiety. I love this drug in PTSD. It's one of the few that actually has an approval in PTSD. For people who have prominent anxiety and depression, this works wonders. You just got to be very selective in who you're going to put on paroxetine. Zoloft is another great drug. Very few drug interactions, very, very, very well tolerated. Unlike the previous drug, it has great data in the extreme populations. It's one of the safest in pregnancy, one of the safest in the elderly, one of the safest in kids as well. So it doesn't get used a whole lot because it's not on a lot of $4 drugs, but it's still a very affordable medication. Most of the time you can get it for less than $20 for a month supply. And you got a lot of dosing flexibility with this. You can go up by 25 milligram increments. So there's a lot of room for adjustment with this particular drug. Looking at them overall, we like them because they're affordable, because they're well studied, because they're safe, because they don't interact with much. Drug interaction-wise, if you pick your right agent, they don't have very many interactions as well. Disadvantages is just the high rate of sexual dysfunction that you can see with them. SNRIs, or sometimes these are called the SSNRIs, are working on serotonin and norepi reuptake inhibition. Does that sound familiar? Everybody should be saying yes. We talked about this with the TCAs, correct? So what's the difference between these and the TCAs? Side effects. They're selective, right? When something's selective, what do we lose? We lost the histamine, the muscarinic, and the alphanergic baggage. Much, much, much cleaner drugs. We also lost a lot of the drug interactions as well. So again, cleaner in that respect. Side effects are fairly common to what you see with SSRIs. A lot of GI type stuff, a lot of headache with them as well, particularly upon initiation. They have a bit of an initiation syndrome. That's just kind of what I call it, where if you come out too quickly on these medications, people feel just very crummy. So you want to make sure that you're titrating these appropriately with them. Same thing as their withdrawal syndrome is a little bit more intense than what you get with the SSRIs. People feel very crummy, very out of it, and kind of gorky when they're on it. Less sexual dysfunction, although it is still a concern. But they do have the potential for blood pressure increases that you want to pay mind to. It's usually not inordinate amounts of blood pressure increases, but you can get an 8-10 millimeter mercury bump. And somebody who's already at 160 over 110, maybe not the best choice for them until you get that under control.